Hello everyone, welcome to another Journal Club with Vestibular First. We are exceedingly happy to have this particular topic discussed. It is the Zuma Maneuver for lateral canal BPPV, and we have with us our very esteemed colleague here, Dr. Zuma himself, to help illuminate us on the challenges that we all face when we're trying to help our patients who have horizontal canal or any kind of BPPV. Sometimes it gets to be more than one canal, so we really have a lot to work on when we have these patients in front of us. So I always like to start our journal clubs with a very brief discussion of anatomy, just to make sure everyone watching who is at different types of experience levels is on the same page. So we're talking about our vestibular apparatus, tiny little apparatus in our inner ear, one on the left and one on the right, and it helps us keep our balance. And inside this tiny little apparatus, we have some sensing organs, and we have a nerve that comes from each of them to the brain, and that input to the brain again is integrated with other sensory information to help us know where we are in space, keep our balance, things like that. Unfortunately, sometimes a condition arises in the vestibular apparatus, which is known as BPPV. Benign means not harmful, although I would argue that a person can get hurt, perhaps from a fall that is caused by the dizziness or vertigo they might experience. And we know that there are folks who don't even experience dizziness or vertigo when they have BPPV, but they will fall. Paroxysmal is the second letter P, sudden onset, and it can come and go. It's recurrent for some folks. Positional means we notice our symptoms with a change in head or body position, and the V stands for vertigo, which is the description that most patients will describe, a sense of spinning of the room or themselves. And I like to point out on this particular anatomy piece that we'll be talking a lot about the canals. So there are three canals. We mentioned the lateral canal, which some people call the horizontal canal. We should mention the superior canal or anterior canal. And then there is the posterior canal or inferior canal. And then all three of those canals, at the end of each of them, there's a kind of bulbous or more kind of large section called the ampulla that's very important for this conversation. And in that ampulla, on each end of each of these canals, there is something called the cupula, which is, I think of it like a sail, but it is attached all the way around on the canal. So as long as it's functioning properly, nothing should pass through if there are little otoconia or our tiny little inner ear crystals that may have made their way out. And that is really what is happening. We have these tiny little otoconia or calcium carbonate crystals. They're supposed to live in the center part of our vestibular apparatus called the utricle. There's an organ there, and there's another one called the saccule, but these otoconia come out from the utricle area. They find their way into one of these three canals. I like to say they're naughty, they're bad, they are going where they shouldn't be. And this movement, when the crystals move in the canal, or if they're even kind of stuck a bit and they kind of pull on perhaps the cupula, anything like that, sends a false sense, usually to the patient, of movement, spinning, off balance, etc. And this is that vertigo type feeling perhaps. And that is how I have been taught by wonderful people such as Dr. Zuma and many other speakers. I have been privileged to hear about BPPV and what it's like. And so I think that's okay as a description. If you want to add something, please, Dr. Zuma, go right ahead.
No, that's perfect. Absolutely perfect. Okay, go ahead.
All right, good. Perfect.
Because the definition is absolutely perfect, the definition of BPPV. Okay, this is a biomechanical disease, as we all said. But go ahead.
Exactly. It's a mechanical inner ear disorder. Totally agree. Most common, barely, in the posterior canal, followed closely, as they've found in recent studies, by the horizontal canal. And I'm sure you're familiar with Dr. Sue Whitney. I just had the privilege of hearing her speak at the Ibero-Neurologic Institute Vestibular Symposium, and she highlighted Dr. Bandari's team's work as well as yours, and talking about how important it is for clinicians to assess the horizontal canal, because historically, some clinicians would only assess the posterior and I guess by default anterior canals with something like a Dix-Hallpike, but they wouldn't necessarily do something like a supine or a roll test to assess the horizontal canals, and so BPPV could be missed. And so then the patient is not getting properly diagnosed, they're not getting proper treatment, and this is not good for them, right?
It depends on where you are. For example, if you live in the emergency room, for example, you can see more lateral canal BPPV than vertical. And there is one approach that my team use a lot. This is a stimulus minimum strategy that was written by Asprelli in 2003. This is a head pitch test. We start with bowing test. After that, if you don't see any nystagmus, for example, you go to Dix-Hallpike test. But if in the bowing test you see, for example, a horizontal canal, go straight to the sit supine position, the roll test. The bottom line, it is pivotal to know where the particles are. You have to define where is the affected site. The success of all maneuvers depend where the particles are. I'm going to show you later.
Yes, right, absolutely. I completely agree. I do not like what some clinicians will try. In where I grew up in Indiana, they sometimes would call something like this the shotgun approach. Clinicians who might say, "Oh, I'll just kind of do a few different treatments and see, if that helps." And I do not prefer that. I definitely agree with you. It's good to know, because the patients can feel quite symptomatic. So it's not nice to them to be doing a bunch of different tests and maneuvers endlessly and without guidance. So I agree that minimal kind of provocation, so that you're getting enough information, right, to figure out what's the right treatment, but not necessarily a whole bunch of other things that would kind of ramp up symptoms. We've all had patients, if you've treated enough BPPV, who are quite nauseous, even if you've pre-medicated them with something like Zofran. And so you really have to kind of walk the line with those patients, I think. So there are quite a few treatments out there, and you all covered quite a few of them in your article, used to treat historically horizontal canal BPPV. I understand from lectures I've gone to that sometimes that's true because horizontal canal can generally be a little bit more difficult to clear on average than posterior canal. Is that your experience as well, Dr. Zuma?
Exactly. The same experience.
Yeah. So everybody tried to get creative and say, okay, well, I only learned this one maneuver and that didn't work, so let me come up with something else. So you have different excellent researchers and clinicians saying, well, let's try the Guffoni. Okay, let's try forced prolonged positioning. And then, of course, your wonderful maneuver, the Zuma. So we will be talking more about that.
It depends on the patients. For example, sometimes I use Guffoni maneuver for geotropic as well, geotropic cases, non-polar arm. Depends on the patients. If the patients are more sensitive, the Guffoni maneuver has two steps only, so it's easier to treat it. But ampulary arm or apogeotropic, this is difficult. I prefer my maneuver.
Yes, and if you have a patient in a hospital and they're in a cervical collar, I've had a couple of those in my past employment, and you can't be moving the head. You've got to only be moving the body in that case, right? So that changes a little bit of what you might do, right?
Exactly.
Yes. So in the study that we're covering, the article that we're covering tonight, you all, as a team, are working to clarify the precise mechanisms of different treatment maneuvers, showing where the debris is somewhat theoretically still kind of, we don't have it exact, but, a pretty good sense of where it would be. based on the software. Excellent job with that. And in that maneuver exploration, you're looking at kind of what's happening with gravity, right? This is a really important helper or hinderer sometimes, but mostly helper to help clear crystals. So we're using gravity and look at, again, kind of where those otoliths or otoconia might be. So I did pull this from your article. It's just giving everyone who's maybe not as familiar an idea of all the different places in the kind of space of the horizontal canal that you might have debris, which is quite a few. You can see there are 5, kind of anywhere from the non-ampullary arm, the ampullary arm, stuck, right? So if they're stuck, it's called cupulolithiasis for those who aren't familiar, whereas if it's floating and kind of sliding back and forth a bit more, that's canalithiasis. And they can be stuck on either side of the cupula, as well as floating in the short arm. So there's lots of different places in the horizontal canal, right?
Because the horizontal canal or lateral canal is inclined at 30 degrees. That's why the anatomy is completely different for the vertical canal, right? And I think to make the matter worse, the lateral canal has a link with the velocity storage mechanism. So the duration of the nystagmus is so long, completely different from the vertical canal. It's at least no more than 30 seconds.
Right.
Okay, so it's difficult to deal with that.
Definitely. No, that makes perfect sense. So we're going to get right into what I consider the meat of this article, which was these various simulations. So I know you probably know them by heart, so I'm going to, instead of reading the words here, I'm going to let you kind of explain, your understanding of each simulation and what you're showing, and then I'm going to play it. So we're going to talk about simulation number 1 first, and I'm going to let you talk us through this while I play it a time or two, okay? So this is the roll maneuver. What's happening here? So the patient's going to lay back, right? And then one.
Lay back and sit supine position. That is very important to me, this position in lateral canal BPPV. Because the direction of the nystagmus in sit supine position show us where the affect side. Okay? For example, if you have a non-ambulatory arm, BPPV, in sit supine position, the direction of the nystagmus beating to the affect side. On the contrary, in the geotropical or non-ambulatory arm, on the nystagmus beating to unaffected side. That is important because sometimes in the roll test, it's difficult to differentiate between the intensity of the both direction of the nystagmus. So the sit supine position is very important to me. I agree. Okay, go ahead.
Yes. All right. So
this is the simulation of ambulatory arm, no?
Oh, and now the head is turned.
Okay. Okay, to the left side. Okay, this is the roll test, you know, the roll maneuver.
Roll maneuver. That's right.
Yes, it works well for geotropic or non-ambulatory arm. Okay. I think it's prone position. The next one is the prone position.
Yes, you're right.
Yes, the prone position. Oh, okay. This is necessary in order to avoid the particles getting back to the canal. Okay.
Perfect. And then they finish the roll here.
It works okay with the non-ambulatory arm.
Got it. Okay, perfect. So now we're going to go to simulation number 2. We'll talk about that one together.
Okay. We start with the sit supine position. Okay. The particulars, I didn't see well. The particulars are in ampulary arm.
Yeah.
Ampulary, okay. Okay, turn the head to the left. You can see the particular stay at the same position attached to the cupula. The next will be the prone position. No. You cannot. And the next one is still in the anterior arm. So you don't solve the problem.
Yeah, it's a failure, I think is what the article says, right? It fails.
Mm-hmm. Yes.
Yeah, got it. All right, so if a clinician tries this maneuver, but the otoconia were kind of in that ampullary arm, they're going to just kind of cycle back into the canal. They're not going to go where they need to go. How would the clinician know that they were in that ampullary arm? Any clues in that first sit to supine that would tell them that, or how would they know?
That's difficult to know that, because, for example, I use the video frames always in my patients during the diagnosis and in the maneuver as well. So you can see where the particles are, okay? And in this kind of this position, prone position is difficult. Sometimes use the video frames, okay? So it's difficult to know what the particles are, okay?
Got
so
it.
I prefer during the diagnosis, the Bowling test and the roll test, because in the maneuver it's difficult. Only my maneuver, we publish a paper with, where the particles are during the Zuma maneuver. But go ahead, and it has nothing to do with this.
Got it. Okay, so our best bet is to do a good bow and lean and a good supine roll test, and those pieces of information would guide us if we should even bother with a roll maneuver, or should we be going to a different maneuver. That's what I'm hearing. Is that right?
Yes.
Understood. Okay, we're going to go ahead and go into simulation number 3. So again, we're starting seated. We're going to lay down into supine.
At the ampulary arm, the particles are attached to the cupula. Now, it's a 360 degree, okay? Turn the head to affected side in order to attach to the cupula. So 90 degree to unaffected side, more than a 90 degree to the affected side. So the particles work well, go well.
Got it.
This was modified. This is work very well for the anterior and posterior canal, posterior arm, lateral canal BPPV. Non-ampullary arm, ampulary arm works well. There is one problem on these particles, in this maneuver. If the particles are attached to the cupula, it's difficult to perform this. Okay, you have to do a brisk deceleration in my maneuver, as a maneuver, or the Guffoni maneuver, or a Piani maneuver. Okay.
Got it. No, that makes sense. All right, let's talk about simulation number 4, which is our Guffoni for
Guffoni.
I believe for geotropic, if I'm not mistaken.
Or geotropic, no ampulary. Okay. Mm-hmm. Okay. You lay down the patient to unaffected side. That's is very important to remind. Okay. All maneuvers start with from the affected side to unaffected side, but Guffoni maneuvers is the contrary. Okay, the nose down, it's work well. Okay, I use so much this maneuver in some kinds of patients. Okay, with heavy problems, neck problem, or neurovegetative symptoms. Okay, I use Guffoni maneuver in geotropic, only in geotropic or non-ampulary arm.
Got it. So here we have what they call the modified Guffoni. That's simulation 5.
It's modified by Appiani. Okay. Now you lay down the patients to affected side. Okay. and turn the head 45 degree or 90 degree upward to unaffected side. Okay. The problem of this maneuver, you're gonna see, okay, you transform the apogeotropic and geotropic because the particle is still there, okay? So you need another maneuver, okay? You can see, the particle is still there.
Right. It's not cleared.
So you have to perform the Guffoni maneuver to another side. This sometimes makes me feel confused.
Yes, no, that's understandable for sure. So here we have, this is the good one, simulation 6 here. We're going to go through our classic Zuma. Let's get this nice and big.
Okay, this is our original Zuma maneuver. Okay, you can see it's the same of the Appiani. Okay, you lay down the patient sideline using the brisk deceleration, which means inertia plus gravity, turning 90 degree to unaffected side. Okay, that's the tips of Zuma. The particles are on the posterior arm. So you just turn to unaffected side one more step.
Perfect. It's like a blend in my head a little bit with perhaps you could say the roll in a way, right? You're just kind of bringing them over. Yeah?
Yes.
Perfect.
But there is one important thing that was a contribution from Professor Richard Rabbit from Utah.
Yes.
Tilt the head slide forward, okay? In order to avoid the particle getting back to the canal. This is a contribution from Professor Hart. Our maneuver, I do this step.
Yes, I agree. I think posterior canal, I've similarly personally experienced tucking a little bit seems to have better results. Would you agree with that as well? I know we're not here to talk about posterior canal, but still. Yes, chin tuck, very good. All right, here we go. Simulation 7 is the modified Zuma.
Yes, we try we publish this maneuver. It's simple only for geotropic cases. For example, you turn the head 45 degrees while the patients are sitting to unaffected side, lay down the patients to affected side, as you can see here. Okay, and they follow the original maneuver of Zuma. Okay, it works very well. But one day, Dr. Anita Bandari called me and said, no matter what, where the particles are, Zuma maneuver works very well for the both variants, geotropical or geotropic.
Got it. That
We're
makes
gonna
sense.
see.
Yes, simulation 8, right? Here we go.
Yeah.
Yeah.
This is the original maneuver. Yes, for geotropic. Okay. That's this maneuver for geotropical non-polari armies is interesting. My colleagues and our team use so much this for geotropic. Why? Because in this step, on the second step, you got an inversion of the nystagmus because we will be inhibitory. At first, excitatory. You had a strong nystagmus beating to the ground. But on the second step, we got an inversion of this nystagmus, the direction of the nystagmus. This is a good prognosis in our patients, okay? You are absolutely right. You are sure that the particles are coming to Uticle, okay?
Perfect. Yes. No, so those are the 8 simulations in this article, all very helpful to watch. So luckily you all can just play back parts of this YouTube to rewatch them as you see fit if you want some review. I find it very helpful to just kind of think and visualize and see the particles. This is why we also have our vestibular first fluid model. People, find it really helpful to, see and feel and watch, these otoconia move with these different maneuvers, both with the video simulations, with 3D models, whatever helps people, because then it really can click why, oh, okay, I can see why this maneuver would work in this case or not in that case and so forth, right?
Yes, but to me, the most important, this device is absolutely perfect in order to learn how does it work. But to me, it's very important to see the eye movements during the maneuver. I'm going to show you in my 3 cases.
Perfect.
I'm going to show.
All right, well, we are definitely ready for your cases, so we will have you share your screen and we will talk through those.
So I'm going to present 3 cases of Zuma maneuver for lateral canal BPPV. First of all, I would like to introduce my colleague and my friend, Professor Renato Cal. He lives in Pará, is north of Brazil. He is my colleague, my friend, and part of our team of research. Renato Cal, Professor Renato Cal, this is a ENT doctor. In Brazil, he is outstanding in BPPV and vestibular disorders as well. So all cases are well documented, as you can see, follow. The first case, one case of BPPV of lateral canal right ampullary arm apogeotropic, okay? As I told you, our team our approach is the strategy of minimum stimulus, written by Asprella in 2003. We start with the head pitch approach, which means the bow and lean test. As you can see here, always under video frenzel. To us, is very important. He is performing the bow test, okay? You can see a nystagma, a first phase of the nystagma beating to the left side. Very discreet in the bow test. Okay? Now he's going to perform the lean test. The head tilt downward. Remember, the nystagma was beating to the left side, less intensity. Now, the nystagma is beating to the right side. Okay, more intense, beating to the right. In this case, for us, the particles are in the ampullary arm or apogeotropic to the right side. If you have any doubt, go to supine position. Supine roll test. Turn the head to the left side. You got a horizontal nystagma with the fast phase or the quick phase beating to the right, beating to the ceiling. Apogeotropic. Mm-hmm. Okay? Strong, intense. Now to the right side, turn the head to this right side. You got an inversion of the nystagma, now beating to the left side. Okay? Less intense. So the particles are in the anterior arm or ampullary arm to the right side. Okay? Now he's going to perform the Zuma maneuver. We start to lay down the patient sideline with the brisk deceleration to affect the side, to the right side. As you can see here, a horizontal nystagmus beating to the left. And the first step. The second step, if the particles are floating in the anterior canal, the direction of the nystagmus will be the same, which means to unaffect the side, which means left side, horizontal left beating nystagmus, the fast phase. And the last one, more 90-degree to unaffected side, and then nystagmus beating to the left side. So I'm sure that the particles are coming to utricle, right? Yeah, the last one, put the chin on the chest and sit the patients and tilt the head slight forward in order to avoid the particles getting back to the utricle. That is the last one step, okay? 2 days after, he retested the patients. Do you remember? And the bow and the lean test? In the bow, the nystagmus was beating to the left. Now, there is no nystagmus. And the patient is asymptomatic, no vertigo more, okay? And the lean, no more nystagmus, okay? We solved the problem. Retest. Once more. With the roll test. No nystagmus to sit supine. Turn to the left. No more nystagmus. Okay, and to the right. You can retest with all kinds of tests, okay? Asymptomatic, they solve the problem. Okay, the second case, a lateral canal, right lateral canal, non-ambulatory arm, or geotrop. We start with the bowling, okay? Always with goggles, Frenzel. The ball test, what happened? A strong nystagmus beating to the right side, with the fast phase beating to the right side. Okay? It's different from the apial geotrop on the non-ambulatory arm, because he is excitatory. Now, in the lean test, you got a inversion of the nystagmus, beating to the left side, not so intense, okay? So, to us, the particles are on the right side, geotropic, non-ambulatory arm. Zuma Maneuver, the original Zuma Maneuver. Take a look. The first step, a strong nystagmus, because it's very excitatory, okay, in this position. And the second position, you gotta have an inversion of the nystagmus. Now it's beating to the right, okay? Excitatory. Now it's gonna beating, I'm gonna inversion of the nystagmus in the second position. It for us is a good prognosis. Okay? And nystagmus is beating to now to the left, to unaffected side. And the third position, with angular acceleration. This is very important, okay? Beating to the left. So you are sure that particles are coming to utricle. And the contribution of Professor Richard Rabbit had tilt forward, okay? Retest 20 minutes after. You remember the bowling test, the strong nystagmus? No more nystagmus on the bow. okay? And the lean as well, no more nystagmus. We solved the problem. He solved the problem. He solved the problem. Okay. Now I'm going to show you one interesting case. A possible canalatized jam. This is here of a lateral canal, right side, in non-ambulatory arm, as you can see here. Non-ambulatory arm. This is a clot, a jam, possible jam. Take a look at this. This video is was accelerated, okay, because it's too long, because the intensity, the duration of the nystagmus is too long. Take a look at the spontaneous nystagmus beating to the left. Spontaneous nystagmus beating to the left. The ball test, always beating to the left. Okay? And the lean test, we expect an inversion of the nystagmus. No, the same direction, same intensity. My gosh. Is it a BPPV? Because there is no direction of the nystagmus. But the history was the BPPV. Okay, let's perform the roll test, supine roll test. Always beating to the left. Always. Thanks God, when he turned the head to the right side, the clot disappeared. So you got an inversion of the nystagmus, okay? He solved the problem, the clots, the jam, and this maneuver, just like that, okay? So, what happened? How to explain that finding? You can see here the clots on the non-ambulatory arm, okay? Here, in non-ambulatory arm. Under gravity, the force of the gravity, this particles move to the cupola under to the negative pressure. That's why you have the slow phase in this direction, and the fast phase to the left side. Okay? This is what we think about. Let's perform the Zuma maneuver to the right side. Okay? The first step is strong in the stump because it's excitatory. Beating to the right. Okay? And the second step, you get an inversion of the nystagmus, now beating to the left side, to unaffected side. Okay? So you make sure that the particles more to left side. Canal jam, possible canal jam. Okay, the last position. And retest the patient 20 minutes after. No more nystagmus. And the first position. Thanks God, we solved the problem. Thank you so much.
Ah, perfect. My pleasure. So I already had a few questions submitted by folks who registered for this event. So I'm going to ask you on their behalf, per their request, for your answers. So our first question is, please, if possible, ask Professor Zuma to deeply dive into an atypical agiotropic positional nystagmus situation.
Sorry, but I didn't understand the question. Sorry.
I will read it again. Ask Professor Zuma to deeply dive or discuss into atypical agiotropic or apogeotropic, however you like to say that one, positional nystagmus.
The difference between apo and geotropic nystagmus?
They want you to discuss agiotropic nystagmus and an
Just
atypical or unusual
an unusual.
unusual apogeotropic nystagmus, perhaps a central or some other issue, an atypical apogeotropic or agiotropic nystagmus situation.
Well, this is one case that I show you. This is atypical, okay? Because there is no change of the nystagmus during the diagnosis, okay? The central, if you talk about central disease, BPP, positional central disease, that is very important when you are examining the patients. Do the oculomotor examination in order to avoid to put aside the central lesions, okay? That's my experience, if I understood the question.
Yeah, no, you're right. And I think the other thing that folks struggle with sometimes is, say, for example, someone has a small cerebellar lesion. Sometimes these do not show on imaging. Is that correct?
Yes, correct. But you can see, examine the oculomotor examinations. If the patient has some, for example, cerebellar disease, if you, for example, do the smooth pursuit, for example, the gaze evoking nystagmus, you can see the cerebellar disease with the eye movements. Always, before perform the maneuver or the test Dix-Hallpike or sit supine position, no matter what, we can examine the bedside examination is part of the oculomotor examinations. This is very important.
Got it.
Okay. I never seen patients with BPPV atypical geotropic. This is, to me, never seen.
Got it. Okay. Our second question is there a short questionnaire related to dizziness which can help to rule out common vestibular disorders?
Yes. There are two things, and during the history of the patient, you have to take in account. The duration of the vertical, in the case of BPPV, the duration is so short, no more than 30 seconds, and the force, my gosh, I forgot the time, and I forgot agora the name of in English.
Yes. You can say it in Portuguese. I'll figure it out. They usually say something like timing and triggers.
The time, what cause? Is spontaneous or forced by some force? For example, the BPPV is always when he turned the head.
Right.
Okay.
Right.
Not spontaneous. The verticals not come spontaneous. Always with the time and the position.
The trigger, yes, the trigger of the position.
The trigger.
I've got it for you. It's okay.
Okay, thank you so much.
Perfect. No.
Timing trigger.
Timing trigger. They're very important. You're so right. And there's even questions within what's called the DHI, which I'm sure you know, but for those who don't know who are watching, the DHI stands for the Dizziness Handicap Inventory. And it's a wonderful questionnaire because there are certain questions that say, when you turn in bed, does this create your symptoms? When you bend over, does this create your symptoms? And there was some studies done that showed that if folks answered yes, so not sometimes, but yes, to those positional questions in particular, there was an increased chance that this patient has BPPV. So to add to what you're saying, if we know the positions, especially turning in bed, because unlike orthostatic hypotension, which is I sit up from lying down and I feel dizzy, or I stand up from sitting and I feel dizzy, turning in bed is not going to be triggering orthostatic hypotension. So if a patient feels dizzy when they turn in bed, it's more likely, yes, to be potentially
Yes.
BPPV, right?
It helps so much, the HD. I don't use every day, okay? But interesting because you can see how can I say, the score
Yeah.
before, after, and before the treatment. This is interesting.
Yes, yes. So it's not, I agree, it's not a tool for every patient, but for certain patients, I think someone who's asking this question might find the DHI to be a helpful kind of additional piece of information. It's not the only thing that you would use to determine a diagnosis, but it's more, like you say, to kind of see after the treatment, especially, how are we doing on those same questions, right?
You have to be careful with you sit the patients, you perform, for example, if you perform the Dix-Hallpike test, you don't see anything, no vertical and no nystagmus. When you put the patient in the sit position, when sit the patients, he got an intensity in nystagmus like a BPPV, and vertigo, very vertigo. The particles are in the short arm of the posterior canal. This is interesting. I have two cases from that. This is interesting.
Yes, agreed. And then that leads us to our final question here from what we had submitted so far. What should we do in cases of concurrent? So that's two canals, either on both sides or on the same side. How should we approach treatment if there's more than one canal involved for BPPV?
Okay. The first one, I treat one canal. Okay? If the patient is okay, I retest this patient for this canal. I treat, for example, she has a vertical canal, posterior canal. I treat with Barany maneuver or Zuma maneuver. Okay? If the patient is okay, no, I'm okay, no problem. I perform the second canal, the treatment of the second, the other canal, okay? If the patients are not feel good, I see the patient the day after, okay? I treat every day one situation. It depends on the patients.
Right, for sure, for sure. And how would you choose which canal to treat first?
The first, it depends on the most strong. Well, they feel more better, but more worse. Okay, that's I treat the first. Okay,
The most symptomatic or
more
canal.
symptomatic. Yeah, the more symptomatic.
Yeah,
Yeah, more
yeah,
symptomatic. Okay.
definitely, definitely.
Yeah.
Got it. Yeah, no, I've heard that from Dr. Whitney and other clinicians as well. So that's what I have done as well. But I know not every clinician is confident to say, "Oh no, it's more than one canal. What do I do?" Especially if you have less experience, it's harder to kind of know what to do. So I agree. Treat that most symptomatic canal. If they're really equal, just pick one. uh, right? But most of the time, one has got more maybe otoconia out in it or whatever, and so you're going to treat that one
Yes.
first, right?
Yeah. It depends on the side of the otoconia, the number of the otoconia, the shape of the otoconia. The lateral canal sometimes is difficult, is more intensive, but in the short arm of the posterior canal is more intensive. This is amazing because the patient, you have vomit, nausea, and vomit
Yeah.
a lot in this case.
Yeah. Yeah. No, I would say, and I believe the literature supports this, and perhaps you can verify as well. In general, if the horizontal canal is involved, it's more likely to make patients more nauseous. That's my experience. Do you agree with that as well?
Yes, I agree, absolutely.
Got it. Okay. Well, I know we're at our time here, and so this is perfect. Thank you so much, Dr. Zuma. It has been a joy to have you on, and you're so helpful because, again, this is an issue that clinicians struggle with all the time. So I know that a lot of folks will get a lot of value out of hearing what you have to say tonight. So thank you very much.
Thanks for
And
having me. I'm so glad, huh? Thank you.
of course, of course. Yes, well, we look forward to
Okay.
hearing from more of you as you publish more literature. We'll watch out for your future articles. I'm sure you're working on some things.
Yes. Yes,
Perfect.
there will be.
Excellent.
Okay.
We look forward to that. So thank you, everyone. I'm Helena Esmond. This is the end of our journal club for tonight. We're happy to have Dr. Zuma, and we'll look forward to seeing you again at our next journal club upcoming.